Ladies and gentlemen, there will be 5 presentations in this session. The distinguished speakers are Dr. Shah Ali Akbar Ashrafi, CRVS Country Coordinator at Vital Strategies, Dr. Khalida Islam, Deputy Director, Institute of Epidemiology, Disease Control and Research, Bangladesh, Mr. Orun Velauntham Salvarez, Client Principal, ThoughtWorks, Mr. Anurag Shankar, Senior Research Scientist, Harvard School of Public Health, and PI, Indonesia Deployment of OpenSRP. And finally, Mr. Shumon Kantri Chaudhary, Senior Research Investigator, Maternal and Child Health Division, ICDDRB.
Now, I cordially request the respected chair, co-chair, and the presenters to take their seat on the stage. At this moment, I would like to request our respected chair to conduct the session.
Thank you. Distinguished participants, ladies and gentlemen, the esteemed presenters. I think this session will focus on the theme 6. It's about, I think, innovative ways to measure universal health coverage and sustainable development goals. We know that monitoring and measuring universal health coverage is very important. And there have been global, I think, guidelines, tools, and mechanisms for measuring. We also have developed the national guidelines, tools, and also the mechanism for, I think, measuring and monitoring the universal health coverage initiative in Bangladesh as well. And different countries actually taken different initiatives. We have got here 5 presenters with us, and I think since the time is very short, like other sessions, we'll be listening to their presentation first, then we'll come back for question and answers. So, one is the first. So I would like to request the first presenter, Dr. Ashrafi, to present and he will be presenting the CRVS implementation and challenges in Bangladesh. Dr. Ashrafi.
Thank you, sir. Respected chair, co-chair, presenter on the dais and audience. Assalamu alaikum and very good morning. So I am Dr. Ashrafi, presenting the CRVS implementation and challenges in Bangladesh. So this is the CRVS history in Bangladesh, a brief history that in 2010, our Honorable Prime Minister instructed to prepare NPR, that is the National Population Registry. And later on, with the support from the UN ESCAPE, we conducted the rapid assessment for readiness of Bangladesh in the CRVS system. And in that rapid assessment, it was scoring at 44%. That is the CRVS system in Bangladesh is weak. So later on, we conducted the comprehensive assessment in 2012 to 2013. And accordingly, we developed a strategy on CRVS in Bangladesh. Later on, this CRVS is coordinated by the Cabinet Division, Government of Bangladesh. And in 2014, there is a establishment of CRVS Steering Committee headed by Cabinet Secretary. And later on in 2015, CRVS Secretariat established in the Cabinet Division. And later on, 2016, Office of the Registrar for the Birth and Death is established. And with the support from the Bloomberg Philanthropies, Data for Health, the CRVS Secretariat is implementing a pilot project at Kaliganj, and it will we are in the first phase, and second phase will start from the July 2017. This is the brief history of the CRVS in Bangladesh. The government is fully committed to implement the CRVS, and it is also mentioned in the SDGs goal 16.9 that by 2030, legal identity for all, including the birth registration, that everybody in the picture. And also in the target 17-18, that by 2020, there is a capacity building to support the countries to increase significantly the availability of the high quality, timely, and reliable data that is disaggregated by the income, gender, age, race, ethnicity, migration, status, disability, geographic location, and other characteristics that is relevant in the national context. So CRBS has 3 segments, that is the registration, certificates, and statistics. It is a cyclic order. And this is the unique approach and global admiration for Bangladesh, that is that we'll develop the one ID that written from the birth to death, therefore avoiding the multiple IDs. Sharing the government resource, therefore lowest possible cost of services. So there will be no new process, and is published a set of standard practice that from the Cabinet Division, the prepared a CCDS, that is the Citizen Code Data Structures, and it will be enable the evidence-based policy making. So technical support for CRBS system that is supported by the Bloomberg Philanthropies and Australian government, and supporting partners are CDC, that is US government, CDC Foundation, Vital Strategies, Johns Hopkins Bloomberg School of Public Health, University of Melbourne, and World Health Organizations. And this CRVS is implementing and monitoring process in Bangladesh that I already mentioned, that CRVS Steering Committee already established, and CRVS Implementation Committee also established under the Cabinet Division, CRVS Secretariat that is coordinating with the other ministries like Ministry of the Health and Family Welfare, Local Government Division, Law and Justice, SIDs, Election Commission, NA2I program, and others. National Mortality Technical Working Group already formed to monitor the medical certificate of cause of death as well as the verbal autopsy implementation under the Ministry of the Health. So in the first phase of the CRVS technical project, 6 interventions were adopted. First of all was the establishment of the Office of the Registrar for the birth and death and reviewing the legal documents. Then another intervention was the notification and registration of all birth and death, both from the facility as well as community. Introduce the verbal autopsy to determine the cause of death where there is no medical certificate. Introduce the WHO standard international form of medical certificate of cause of death and improve the cause of death in the facility. Introduce the training of appropriate staffs in ICD and mortality coding, and capacity building for the critical appraisal of the vital statistics. So these 6 interventions are taken for the first phase of CRVS. So the piloting areas are for birth and death notification and registration, including the verbal autopsy at Kaliganj, Gazipur, and for implementation of WHO standard medical certificate cause of death in the facility, the piloting area are the Sir Salimullah Medical College and Mitford Hospital, Shohid Sohrawardi Medical College Hospital, Shohid Tajuddin Ahmed Medical Hospital, Gazipur, and Kaliganj Upazila Health Complex, Gazipur. So there is a law in Bangladesh that all the birth and death should be registered by the civil registration office within the 45 days. But the coverage of registration of both birth and death is very, very low. Right now, within the 45 days, the birth registration coverage is less than 3%, and death registration within the 45 days is less than 1%. So we identified a model and introduced the health system to notify the birth and death registration or events, all the events, to the local registry office, so that all the birth and death should be registered within the 45 days. So this process we are practicing in the Kaliganj, and after the process, the achievement is that. So this starts basically in the last year, August of the 2016, and up to the December, that if you see that within the 45 days in the 2014, in the Kaliganj, it was only 54. And in the 2015, it was around 350. But after taking the initiative from the CRV Secretariat Cabinet Division, with the support from the vital strategies, it was around 1100. So within the 45 days in the Kaliganj. So this is the model we already identified in the rural system, in the rural area, and engaging the health system to notify the birth to the local registry office. Simultaneously, the death registration also improved, tremendously improved in that area, piloting area. If you see, in the 2014, it was the around 300. In the 2015, around 300. But in the 2016, it is around 1100 and more. So we engage the health assistant and FWA to notify all the events of the CRVS to the local registry office, so that it should be registered and it should be pictured in the government system or government database within the 45 days. So this is the process of the birth and death notification and registration that is practicing in the Kaliganj right now. So you know that the birth and death registration application form, that should be signed by the applicants. So all the forms are available to the workers, both health assistant and FWA. So during their domiciliary visit, they fill up the birth and death registration application form with the support from their parents or relatives. Then they forwarded it to their respective supervisors, that is their assistant health inspector or family planning inspector, for verification at the community clinic level. From the community clinic, they submitted it to the local registry office for issuing the certificate, registration certificate to the family members. So from the family members, the workers again collect the either birth registration number or death registration number. Birth registration number is needed for the immunization card. If you see the new immunization card, there is a mention for the birth registration number should be entered in the immunization card. And for the death registration number is required for the verbal autopsy. So by this way, or by using this model, we are achieving to their government and birth and death registration rules 2014, that all the birth and death should be registered within 45 days. So the health workers is conducting the verbal autopsy using the tab and in using the digital questionnaire, that is for the verbal autopsy and smart VA. This is the picture. And this is the findings of all the death that were registered and verbal autopsy done. So if you see that the adult case-specific mortality fraction, that the most common cause of death in the community is the acute myocardial infarction, followed by asthma, stroke, and diabetes. All are NCDs related, non-communicable disease or non-communicable disease. If you see the child case-specific, cause-specific mortality fraction, the drowning, child means 29 days to 12 years. So drowning is the most common cause of death in the community. Road traffic accident, followed by diarrhea and other. And in the case of neonate, that is most important cause of death in the community, either meningitis or sepsis, followed by pneumonia and birth asphyxia. So all the causes of the death were unknown previously. After using the verbal autopsy, we can identify the cause of death because there is no medical certificate. Follow up the MCCOD, that is medical certificate cause of death in the facility or hospitals. Patient dies in a hospital, then the doctors fill up the form MCCOD form and death declaration form. And they supplied this death declaration form to the family members for funeral activities. And senior staff nurse and medical record keepers, they are filling the MCCOD form in the DHS2, and from the DHS2, it goes to the local registry office with notification with cause of death, including the ICD-10 coding. And simultaneously, dashboard is prepared at the MIS DGHS, local hospitals, and national levels. So this is the form that is introduced by the WHO last year, April 2016. That is the international form of medical certificate cause of death. And this form is piloting in the 4 hospitals where there is underlying cause of death, and immediate cause of death with the ICD-10 coding. We developed a group of coders in the 4 hospitals. The challenges in Bangladesh for implementation of the CRVS is the awareness, building awareness among the stakeholders, making the stakeholders working together, because information coming from the health to the local registry office, from the local registry office it will go to the BBS for preparing the vital statistics, and going to the election commission for updating their database. If anybody died after the 18 years, so NID should be updated according to the information from the registry office. They need an integrated IT system, and this model is only for the rural area, but we have no idea about the urban settings, because urban is fully run by the NGOs and INGOs and the local government divisions. In the primary health care, all the NGO hospitals or clinics are run by the different agencies, not the Ministry of the Health. So in the urban setting, this is a challenge for the CRVS implementation, especially the notification of birth and death from the community as well as the facilities. And obviously, for nationwide scale up, we need the funding, and we are welcoming the development partners for improving the CRVS system and implementation in Bangladesh. So conclusion is that CRVS is not just a right, it is a powerful tool to achieve the policy goals. It requires certain level of institutional capacity and data quality, and it is a benefit hugely outweigh the cost, and we need to get better at analyzing and communicating, and needs coordination and collaboration with the development partners and international agencies also. So this is the picture of happy mother with a birth registration certificate and immunization card. Thank you. Thank you for listening.
Thank you, Dr. Ashrafi, for sharing with us the outline of the CRVS, the status of implementation, and also the challenges. I think it's a very challenging task, however, it will be very useful. So now I am just requesting Dr. Khaleda Islam, Deputy Director, IEDCR, to make her presentation. She will be presenting the cell phone-based reproductive health surveillance of women in Bangladesh.
Respected dignitaries at dais, distinguished audience, a very good morning to you all. I would like to welcome you to the presentation, Cell Phone-Based Reproductive Health Surveillance of Women in Bangladesh. We focused on collecting data regarding the reproductive health status, and it is okay now. It's okay. So we focused on exploring reproductive health, morbidity status, and also we wanted to establish a cell phone-based disease surveillance system to reach up to the community to collect the real-time data regarding reproductive health. The Sexual and Reproductive Health Services and Information Division of Directorate General of Health Services Office provided technical support to this activity. So, why we have chosen cell phone based disease surveillance system? It is because we wanted to cover the whole Bangladesh, and it easy to cover geographically, less expensive, allows flexible timing and movement of the respondents. It avoids social desirability factor, which is present in case of face-to-face data collection. It also avoids the influence of other family members who may be present while one interviewer collects face-to-face data. If we look at the cell phone network of Bangladesh, at the moment the geographical coverage is 100%. The teledensity or cell phone penetration, it is 74% about. Before biometric registration, it reached up to 84%. And most importantly, there is no incoming call charge if we receive a phone call. So, respondent, when we call them, they feel very relaxed to talk to us. If we look at the operators operating in Bangladesh, there are 5 operators, and the most share goes to Banglalink, which is 46%. So, if we would like to share a little background why we chose cell phone, IEDCR has the experience of conducting cell phone based disease surveillance from 2012. We piloted a surveillance in Dhaka City Corporation area. We followed the BRFSS model, that is Behavioral Risk Factor Surveillance System of US government, which is technically supported by US CDC and implemented by the National Health System in the US. And that is the most largest cell phone based disease surveillance conducted at the world at this moment. We followed their protocol, and one technical advisor from CDC Atlanta supported us in developing that protocol. We did the pilot project. We found the results are very good and comparable to the nationally available data. But we didn't stop at that time. We wanted to validate our cell phone based data collection method with face-to-face method, considering the face-to-face method as a gold standard. So we, on a subset of sample, we collected face-to-face data. When we did statistical analysis to check the reliability and validity, we found that with most of the indicators, the percent agreement, kappa and McNamara test, it goes up, and also the sensitivity and validity are very good. But with some indicators, it is not very good. So we realized that while we will be collecting data, we have to emphasize on the indicators and the variables which are not very clearly understood by the community of Bangladesh, like physical exercise, like hypertension. Whenever we start talking about hypertension, the respondents, they immediately start talking about low blood pressure, etc. So we realize that we have to give emphasis while we ask them the question. We have to make the question very clear to them. And we took several steps to involve all the operators, because initially the operators were not very cooperative. What we did, through our Director General of Health Services and Honorable Secretary, Ministry of Health, we wrote a request letter to the BTRC chairman, and BTRC chairman wrote to all the operators to support us with respondents number. And we also extensively organized consultative meeting with all the operators, with the BTRC colleagues and the other stakeholders. And after taking all the preparation, we scaled up our surveillance system nationwide. We conducted several communicable and non-communicable disease surveillance, and by this time we learned and we gradually improved our methodology. What we did with cell phone based reproductive health surveillance. We reviewed the documents, we get approval from IRB, and we conducted several preparatory meetings with the technical experts in the field, with the program managers and policymakers. Then we developed the questionnaire as well as field tested the questionnaire, making phone call. Then following the questionnaire, we developed the data template. We recruited the interviewers, trained them extensively, not only on interview technique, but also how to insert data while they conduct the interview. Meanwhile, what we did, we advertised in the paper, targeting all the respondents that we are going to send out these phone calls. So please cooperate us, because all of us sometimes become afraid of picking up a known number. We wanted our study to be scientifically sound. So what we did, we calculated the sample size, and based on the population proportion, we distributed the sample size division-wise. Then we picked up the market share of the operator and distributed division-wise, market share-wise sample size to a whole country. We requested the operator to give us 5 times more numbers so that we can insert the number into the database. Whenever one interviewer opens the data template, a randomly selected phone number pops up, and when she clicks on the number, it goes directly to the cell phone. Based on that, the interviewer calls the respondent. If she agrees, after listening to the objective to provide the interview, the interviewer continues the interview. And while she continues the interview, at the same time, she inserts data into the data template. We conducted our interview from 8 a.m. to 8 p.m. in 2 shifts, and the interviewers were working in roster basis. We conducted monitoring and evaluation of the interviewers. In 2.5 months, we collected 7,694 completed interview, and the graph shows what we calculated to collect division-wise complete call. We were almost there. And the socio-demographic characteristics, we have all the data which are, after analysis, we are comparing with those data at national level data, and we are looking at how cell phone based data is, how it is comparable to face-to-face method. As you see, we found that urban population is less, mostly rural population, our respondents. The house managers, they are more. Educational status-wise, SSC level, that is the school, 6 to 10 year schooling maximum. Mean age of our respondents. Age at marriage, it is about 16.9 years. Age of first pregnancy, 18 years. And the respondents' mean age was 29 years. And also, 57% of our respondents were married before 18 years of age. And their first pregnancy, 41% of their first pregnancy was before 18 years of age. We have lots of data. We are analyzing this data. We are continuing it. And if we look at the 3 signs or 3 danger signs of pregnancy, we have seen it, the respondents who can mention 3 signs, it increases with education. And other data we have as well. We also looked at the comorbidities. We found 10 respondents having comorbidities. We have collected their data. We will be communicating them afterwards. Challenges. We have lots of challenges. We received return call. We received unsolicited text messages, and we could not mask the caller ID because of BTRC regulation. So interviewers have to face difficulty in authentication that they are making a phone call from IEDCR. Reaching hardcore poor is a challenge for us who doesn't have a cell phone. And timely recovery of respondents' number from the subscribers is also a challenge. What we shall do now? We would like to do a validity survey on a face-to-face, using face-to-face method on a subsample. We also would like to approach the respondents who are having comorbidity. We would like to establish this surveillance system so that we can help get proper information regarding reproductive health, and we hope with this surveillance system we'll be able to ensure universal health coverage for reproductive health programs in Bangladesh. Our deepest gratitude to all those listed in this slide. And lastly, if you are holding a Bangladeshi SIM, your number may be picked up randomly, and on a fine moment, you may receive a phone call, a sweet voice saying, "Sir, I'm speaking on behalf of Institute of Epidemiology, Disease Control and Research. We would like to have some information about your health. Do you have some time? Please say yes and give the data, because we are collecting the data anonymously, and this is for public health interest of the Ministry of Health and Family Welfare." Thank you so much.
Thank you. Thank you, Dr. Khaleda Aslam, for leveraging a very popular and ubiquitous media to address a nationally important issue of reproductive health. Now we are going to listen to a presentation which has a very catchy name. It's implementing a shared health record platform in Bangladesh, wins, challenges, and opportunities. Mr. Arun Velayetham Selvaraj, please.
Thank you, sir. Respected co-chair, my fellow presenters, and the audience. Thank you for having me here. Before I begin, I have a confession to make. When the time for the presentation was reduced to 10 minutes, in fact, I had to prepare more. So earlier I was just going to speak from my experience, and now I had to really keep it short. So I will try to keep it short. So today I'm going to, I've been fortunate to work on an innovative shared health record solution for DGHS over the last year and a half under the guidance of Professor Azad. So in today's talk, I will try to cover and provide a quick introduction about shared health record and its relationship with health information exchange, some of the wins we've had, challenges we faced and overcame, and some opportunities probably that lie ahead. To begin with, shared health record facilitates clinical information. And HIE, or Health Information Exchange, is the mobilization of healthcare information across the entire hospital system. So shared health record is a part of Health Information Exchange. OpenHIE is a concept for enabling such health information exchange. The implementation is left to people, and it's not prescriptive. As you can observe here, the shared health record is a component within the HIE concept. Here in Bangladesh, we have enabled the entire HIE platform, including the shared health record, which is the component. However, we have made some subtle adjustments to this concept in the implementation in Bangladesh. Bangladesh HIE has been evolved for DGHS over the last 3 years. some of it consisting of existing systems. And the entire vision is to connect all the facilities, the hospitals, clinics, all the facilities to the central system, and thereby collecting all encounters of a patient. Now, if you look at one of the boxes, which is called the Master Client Index, just taking an example, it's also called as patient registry in the OpenSRP world. It ensures uniqueness of a patient record, and it follows the Bangladesh CCDS standard. Terminology registry as a component there ensures the language is common when the information flows from one facility to the other. The goals of HIE actually vary depending on the type of people accessing the information. For example, for a policymaker, public health reporting is a huge gain from having a system like HIE. Whereas for a provider, it is the clinical history. And as a patient, you get a portable health record. Let's look at some wins. When we started the pilot, we looked at the entire structure, the health structure of Bangladesh. So it's a usual pyramid structure where the tertiary hospital is at the top of the pyramid and the community clinic at the bottom, or the base, I would say. And in between are the primary and secondary care. We piloted BAMNI, or an OpenMRS based system, in a district and as well as a sub-district or Upazila hospital, and a lighter version of BAMNI, which is the community health worker application in the community clinics. I'd like to point out that there are other systems like OpenSRP and RHIS also being piloted in the community health space. All of these systems actually interconnect to the central HIE, or health information exchange, thereby providing clinical history data to it. This then gets aggregated and reported to DHIS2, which can be used for national reporting. So the completion of pilot around mid last year was a huge win for us. This demonstrated clearly that such a solution was possible and it's beyond concept. And we could clearly demonstrate the capability of both SHR and the health information exchange here. The photo there was taken at the beginning of the rollout at Kaliganj Upazila Health Complex. We did have challenges along the way, and we did overcome some of them. So HIE being an emerging concept, the implementation is never straightforward. And so the challenge was to do a thorough study of the context, the existing systems, available standards, and decide on a path. To pilot such a system, also, we need a client system, because being a central system, you need a client system to be available to do a successful pilot. So we chose BAMNI, OpenMRS based system, and integrated to SHR, and also built a community health worker application that would integrate into the SHR solution. Once we decided on what the scope for pilot is going to be, then we realized the gaps that we need to solve. In order to execute towards a pilot, we had to run it like a program of work. So we had to look at the program level milestones at one view, and the different streams that form the part of the program at a different level. And we had to track it very closely to ensure that this pilot was going to be successful. The teams were also distributed. We had teams in Bangalore and Dhaka here and Kaliganj. So we had to constantly be in sync through conference calls and Skype calls to ensure that we are making continuous progress. There was a governance team constituted to help us by the DGSS to help us set and manage expectations with key stakeholders. Infrastructure assessment before we began the pilot, uncovered gaps beyond the servers, the switches, the LAN, etc. The gaps involved even the absence of a registration room, so which had to be built, as you can see in the photo, and even a safe room for servers to be kept. We had to go ahead and address these gaps. Sometimes we had to make a decision to go ahead even as the gaps were being addressed. So for example, you can see people, we started the pilot even before the registration room was built. Now users had a day job to do. So training a whole bunch of doctors, nurses who were busy with their day job was going to be a challenge. So we had to run this as even the training itself as a mini project. People, the doctors and the nurses would come in 2 hours early or 2 hours later, stay back 2 hours later to ensure that they learned the system. And this dedication towards actually spending a long time in the work, both learning as well as doing their duty, inspired us to also work long hours. The rollout to the entire hospital at a single go was clearly out of the question, mainly because of the size and the staffing constraints that we had. So we had to do it in a phased manner. And even during the rollout, we had people at different areas to monitor the progress and ensure that we come together to solve the problems that we face. So we had to be thinking on our feet. Working long hours for a stretch of 3 to 4 weeks clearly creates, it takes a bit of a toll, right? So we had to find ways to entertain ourselves. This is our team going on a small trip near the Kaliganj river. And also, enjoying the local food and having a bit of fun. We had a great group. There's still plenty of challenges that we need to solve. It's not all rosy. But I think we are on a journey to solve those problems as well as think big. So more recently, for example, we've endeavored to introduce a health ID card that could be, that could curb the duplication of registration that is happening in Kaliganj. So looking at some of the opportunities, now we are looking at when this gets rolled out at a national scale, shared health record being mentioned many times. It could pave way for real-time data collection and real-time responsiveness to health interventions. And also, it paves way for us to link to other tech initiatives that are happening by having a central platform. Now, with respect to UHC as being the topic, definitely there's a conceptual view that we could have in how the central health information exchange platform could be leveraged. As an example, the patient registry here could be extended to capture information around insurance identifiers. So there's an opportunity definitely to leverage the platform towards universal health coverage. Finally, all this wouldn't have been possible without close collaboration and close collaboration with the partners that we worked with and the people who supported us throughout this journey. My sense of deep gratitude for everyone who was there with us. We've made many friends, and this partnership hopefully endures a long duration. Thank you.
Thank you, Mr. Odun, for portraying a very practical picture of introducing a new sort of initiative. Thank you. So now I am going to request Dr. Onuraj Shankar just to make his presentation on OpenSRP Indonesia.
Okay, thanks very much. It's very good to be here this afternoon, and very nice to follow on some very nice presentations today in the morning. So I'm going to speak with you about OpenSRP Indonesia. We had a nice presentation yesterday from MHealth around some of the OpenSRP work here in Bangladesh. But First, I want to talk a little bit about this issue of universal health coverage. Of course, the World Health Organization says all people, irrespective of socioeconomic status, should have access to quality health services they need without incurring any financial hardship. So that's really the goal that we're after. The means of that really would have to be delivered through frontline health workers. And as we all know, most countries have a core of frontline health workers. But these frontline health workers really face a lot of challenges. And I think we've seen these overview the last couple of days, today and yesterday, around these typical challenges these frontline workers have using paper-based registers. And there has been attempt to move away from paper-based registers and use electronic registers in some way, but we're really still in the infancy there. So this is still the situation we see lots of places, here in Bangladesh, Indonesia, lots of places. And so there has been this move towards these MHealth solutions. And I just wanted to go through a little bit just to understand the evolution of this in a sense, and how this has shaped how we think about things. So these first generation MHealth solutions were essentially just entering data onto a phone or a computer. And there was a lot of excitement at that time. This probably started 20 years ago, maybe, or more. Excitement, wow, you could data or that was on paper, somehow now you could see it on a computer screen. This kind of first generation MHealth was basically for collection of information. It wasn't for really actionable information at the time of collection. Second generation MHealth really started processing information at the point of collection. So things like smart flags that would alert a health worker and say, well, this person has hypertension, their blood pressure is high, and maybe you can take some action on that. So this was really the first sort of two-way information flow. By the time we got up to third generation, which really started emerging, I would say, maybe around 10 years ago, this was systems where information would be reported to a server of some sort. There would be additional processing of that. SMS or text messages might be sent out to a field worker or a client in the field. And so there were multiple sort of two-way information flows, information coming in, text messages going out, smart reminders going toward the frontline health worker who had collected that information in real time. Now we come to these fourth and fifth generation approaches. So the fourth generation approach is essentially collecting information and coordinating it amongst more than one frontline health worker. So you essentially have three-way information flows. This is something that we're just beginning to pioneer now. And fifth generation, of course, these are the learning systems, the artificial intelligence-based systems where information comes in. The system learns from that, looks at patterns of how a health worker is performing or how a client is acting in some way, and takes some action on that. So most of the systems we have today, in fact, are up to around third generation. We're still, in fact, deploying systems on a regular basis that are first and second generation solutions. First, second, and third generation solutions are things that you actually can achieve using a well-run paper-based approach. You can't do fourth and fifth generation work without using the data that's collected. So that's one, I think, important thing to keep in mind. So our goal when we started OpenSRP essentially was to think about how do we build an app and a system that health workers deserve and that clients need to have, because paper-based systems can't provide that. And simply providing same functionality that you can achieve on a paper-based system, but an electronic-based system, it's fun and interesting perhaps for all of us and for developers, but it's not really advancing the health delivery as such. The key is to be able to use the data actively for decision making, and we've certainly heard a lot about that. So several of us started developing many years ago this Open Smart Register platform. What is OpenSRP, in fact? Well, it's an open source set of codes really for using as a starting point the paper register for frontline health workers and developing a core build that can then be adapted to country-specific applications. So there's a Thrive consortium, I think Amrita spoke about this. It's a group of organizations, academics, and other in-country organizations essentially in Pakistan, Bangladesh, and Indonesia, and in South Africa, working on a core build. And the way that OpenSRP works actually in this Thrive Consortium is any organization can decide to join to be a developer of OpenSRP, and the key is to assemble a country-level group of people who are interested. They can go to GitHub and they can do a download of the app and start changing it so it suits their own application. So this is this OpenSRP platform. It leverages very much open source apps, open source platforms that are out there already, and this helps to facilitate this interoperability. As I mentioned, currently we're deploying in these 4 areas, and this is a core build that you can go to GitHub and acquire these. There's an app you can use on an Android tablet, a phone, and start to change those to suit your needs. This is a typical antenatal care view. I think we saw an example of this yesterday. Here's a vaccine app, tracking vaccines and so forth. So the starting point is a paper-based system, but then it gets changed after that to facilitate the workflows of the worker themselves, and currently expanding to several other countries in the world. And today, this is really where we're looking at different OpenSRP deployments. So this is really the strength of OpenSRP. It's a scalable, open source, enterprise-level architecture. It's intended to manage the data ecosystem from the clinic to the home. Just like OpenMRS, it's intended to manage the data ecosystem at the health clinic, and DIHS2 is to manage sort of the larger health information system along with OpenHIE. Really, OpenSRP is about this ecosystem from the clinic to the home. And it focuses a lot on user-centered design. So what about OpenSRP Indonesia? So these are some challenges in Indonesia where the country is actually decentralized to the district level. And so each district of 600 some districts in Indonesia have an interest in having their own health information system in some way. And their forms, frontline worker forms and so forth, might be changed in some way. So you need some system there that is highly flexible, that can be developed in country, where you can have a group of developers that regularly go through and update the system. And I think many other countries need this kind of solution as well. And of course, Indonesia is a large country, it's an archipelago spread over lots of areas. So we developed a OpenSRP deployment for Indonesia using the paper forms that the frontline workers were actively using there. The skilled birth attendants, the antenatal care providers and skilled birth attendants were the first case where we developed the OpenSRP for them. And we're currently deploying in around 122 of these frontline workers, covering a population of around 900,000 persons, I would say. So the key was really developing this user-centered approach, where you're working with the frontline workers and asking them not only what they collect on the paper register, but really how they use the register, how they use that in their consultation, and doing the modification to OpenSRP to make that possible. So you go through a lot of incarnations, and the idea of this is to enable them to have an app that really helps them do their work more effectively. So this is just the typical view of the start screen. This is another example of how the information appears. And there is a dashboard, of course, for the supervisors, where they can go on in real time, look to see what's happening there. I think several other frontline systems have this. And this is another feature that they asked for that was developed specifically for them. It's called a head, heart, hand score, where the data from each frontline worker is used and assembled every day, actually, for the last 30-day period to look to see how they're actually performing. The head score is what they know about their job on some exam that they took. The hand score is, you can see there, basically on-time visits, completeness of data. And the heart score is similar to the hand score, but for high-risk clients. Here's an example of some of that data. You can see people's knowledge. You can score 100% or a 1 on each of these, and you can see that people's knowledge of what to do was always much better than actually performing it. And it's interesting that I think when we look in aggregate of how frontline workers are doing in general, there's a large gap there, not because of lack of effort, not because of unwillingness, but I think the support that frontline workers need is there's a gap in the health system of how we actually provide that, both from salary and other means. This is just another feature, the child growth monitoring. They can see immediately how the growth is of a child and take action on that immediately. And I want to come to this one last point here, which is very important, which is that we have implemented this process where workers can share data amongst themselves. So we can deploy OpenSRP with more than one frontline health worker, a vaccinator, a nutritionist, and of course the skilled birth attendant, and they share data amongst each other. And that's important because currently in most places of the world, healthcare on the front line is a provider-centered approach where clients have to go to different providers. This approach of sharing data changes that completely into a client-centered approach where frontline workers can be organized as teams of people focusing on clients. So it's probably the greatest change in how frontline workers are deployed since the development of primary health care. And I want to show you one more thing actually. In order to facilitate this, we incorporated into OpenSRP for the frontline workers facial recognition of their clients. So when a client comes up to them, they just hold up their tablet and there's instant recognition of the person, but the vectors of these faces are in fact shared across the multiple frontline workers. So if I see a worker today, the vector image of that person, how they appear, is shared with all the other frontline health workers, and then if I go see another frontline worker tomorrow or 3 days from now or next year, I'm recognized by that person and all my information emerges there. So I don't need a fingerprint, I don't need an ID card, it's just based on the facial recognition. So I think I've already overstepped my time. Let me just skip to the end here. So OpenSRP Indonesia has some key innovations, pervasive real-time sharing of data amongst frontline workers, facial recognition, and there's this chatbot artificial intelligence entities I didn't have time to show you. But we're currently conducting an RCT, randomized controlled trial, looking at the actual impact of OpenSRP on quality of care and health outcomes to see whether or not this sort of data management actually has some sort of impact on the population and the ability of the worker to perform their job. So thank you so much for your time, and thank you, speakers.
Thank you, Dr. Amiraj. Yes, for sharing us with an innovative, I think, platform, and hope that it will contribute to improve the service delivery. Thank you. So now I am going to request Dr. Suman Kanti Chaudhuri of ICDDRB to make his presentation. He will be presenting the transforming service delivery process of government health workers and promoting data-driven decision-making through digital innovations in Bangladesh. Dr. Suman.
Well, welcome everybody. Thank you, sir. Although I'm not a doctor, but today I'm going to talk about an initiative going on in Bangladesh, which is actually transforming the primary healthcare services at the community level as well as at the union level facility in a context where actually we have two separate streams of service deliveries. You can see on right hand side the figure shows actually both DG Health and DG Family Planning, they have different tiers of service deliveries. I have taken here up to the district level facility, and these two streams are actually separate. They have duplication of work at some point and also duplication of reporting. The figure on the left hand side, you can see the green bar is actually for family planning community workers and the blue bar is for health community workers. So you can see here, out of many services at the community level they provide, the yellow boxes are actually duplication of activities. Both health and family planning community workers, they provide maternal newborn health services as well as under 5 child care and also births and deaths notification. So when at the end of month, when we try to get a number of a catchment area, how many pregnant women we have, we get actually two figures. The question is whom to believe. So we have two figures of many indicators. Those are being actually collected by both health and family planning workers. So we have this context, and also, that this is a common picture in many countries, high volume of paper-based registers and reports. And this is causing overburden. And there's no functional linkages between community and facility level. The figure on the right-hand side, the data doesn't travel to the different service delivery points. The data collected at the community should be available at the different facilities so that the service providers at the facility level can retrieve that information and provide appropriate services. And also there are multi-level compilation. You can see here the figure on the right-hand side, all reports from the community and different service delivery points below sub-district level comes to the sub-district level. And it follows actually different levels of compilation, and it creates chance of errors. We have also opportunities. There is hope. We have strong leadership at the national level, and also we have political commitments. And there's visible increasing understanding. I can tell you there's visible increasing understanding about the needs of data from routine sources, and the conference like this tells you really the real situation. And we also have countrywide internet connectivity through mobile networks, although the strength of network is questionable in rural areas. And we have availability of electronic devices at the local level. MHealth already provided different types of electronic devices up to the community level, and family planning is catching up soon. So we can dream now of a robust system at the source level which will serve the universal health coverage or post-MDG goals. This is sustainable goals. And since Bangladesh has been recognized as a role model in different capacities in the world, so we can develop a system that is robust, and we can show the world that you can follow this to strengthen your routine health information system, particularly at the source level. Ideally, we have a system that actually collects denominator data system overnight. It will create chaos. The system should reduce MIS-related workload, but at the same time, it should improve data quality. The system may have artificial intelligence and validations. And also, this real-time individual data should be available and accessible to the supervisors and managers, and the reports should be generated automatically and directly from the source level to DHIS2. So for USAID partners, Major Evolution, ICDDRB, SIOPS, Mamuni Health System Strengthening are working collaboratively with MHealth and family planning to transform their existing service deliveries into different apps. I have taken this slide from a shared health record presentation. I think you won't mind. So this shows actually the MHealth health information, the architecture. So there is system for hospital, there's system for community clinics, and the EMIs is actually system for community health workers and union level facilities. And it will be linked with the DHIS2 for aggregated report generation. So what is EMIS? I have tried to draw the conceptual flow so that you'll get an understanding of what actually EMIS is. It starts with the population registration. So we need the denominator database. We need to have the database of all population in a catchment area. And also, we should have the unique identifier. So we are providing health ID card, and you have seen that in the presentation, SHR presentation, actually the idea SHR has taken from us, how we can provide them health ID. So that this health ID has a unique health ID number, which is taken from SHR. And using this population database, either family planning community workers or health community workers, when they'll be visiting a household, they'll be registering a person and providing the service, and the service provided by the family planning community workers will be available to health community workers. So if any pregnant woman is registered by family planning community workers, health community workers doesn't have to register it again. because it's available in his tablet. So what he will do, he will just update the other information. And when he will update other information, it will be available to the family planning community workers. So the duplication work is reduced here. And also, when we are in need of getting data on certain indicators for a catchment area, we'll get the same number every time, because the population database will give that actually. And these systems are also linked at the facility level, at the union level. So the service providers at the union level, when a person will go to that facility, the provider will retrieve information from the population database, and she will or he will provide services. And the services will be provided at the facility level, will be available both at the community, family planning, and health workers. So this is the comprehensive system, robust system for community health workers as well as union level facilities. And the EMIS module we have already developed, a service module with integrated population registration system. You can see for family planning community workers, health community workers, and also for union level service providers. And also we have developed the e-supervision system for their immediate supervisors and managers. The monitoring tool we have is actually helping the managers to track the progresses, as well as some management activities like provider management or area assignment. Currently, the EMIS initiative is going on in 2 districts, Tangail and Hobbyganj. In Tangail, ICDDRB is actually providing the technical support, whereas in Hobbyganj is Mamuni Health System Strengthening. And both districts actually is covering 20 sub-districts. It's more than 190 union-level facilities, more than 5 million people, more than 2,000 government, community, and union-level facility workers. Already we have provided more than 1,800 training to the 1,800 government staff, and we provided devices and internet connectivity where necessary. And soon we are going to scale it up in 5 more districts, with 1 district will be supported by DG Family Planning by their own, although these districts are not fixed yet. So the demonstration activities in Tangail, here in 3 pictures you can show we provided training. We had regular supervisory visit by high-level officials, and instead of using paper-based register, they are doing their activities in tablet. We have started getting data. Already more than 3 million population registered in Tangail. More are coming.
Pressure, that's very uncomfortable. Why would I want to use a tablet for that? I've only had to negotiate my work with my direct supervisor, and this person is happy. Now I'm going to use electronic, and I have to negotiate my performance with hundreds of other people seeing what I'm doing every day. I don't like that. So from a social, our challenge in all this transparency and information technology is the social challenge of it. And I'll tell you one interesting experience that we had. In Indonesia, and I suspect lots of places, there's data fabrication. I don't think this is a big surprise for anyone. But another area where the data are fabricated is when a report is created. So once a month, lots of workers have to do this data aggregation. So often the fabrication is at that level. How many cases you had of XYZ, how many antenatal care visits you did on time, et cetera. So in the OpenSRP platform, there's a space for the generation of that monthly report. And so usually this is generated through the standards of the government or the World Health Organization, saying this is what you have to say. ANC goes up to the X number of weeks gestational age, ANC 1, 2, 3, 4, and so forth. So these frontline workers, they asked us, they said, listen, can you create the aggregated reports with what they called informal indicators, like we usually aggregate it? So they were essentially asking us, help us to fake our monthly reports. So I agreed to that. And I got in a lot of trouble for it. But I agreed to that because this was something that they wanted to be able to use the system, for them to see there's use in the system. Otherwise, they would say, no, we don't want to do this. And once you have the actual information collected, you can aggregate it any way that you would like. So over time, we were able to work with them and say, look, your informal indicators and your formal indicators, it's not that different. So you can improve over time. So I think, again, that whole process is extremely important. The one thing I want to add really, really quick is just to say that the other thing we've learned is having all these processes be open. Open source software code that communities of developers can work on locally. I think that's a very important thing that we've learned to make these systems as sustainable systems. Thank you.
Thank you, Dr. Shankar, for covering many of the grounds that our two from audience, they from the question to the panelists regarding how all these are going to help to move USC agenda forward in this country, maybe, and that's very important. I think we need, of course, we need the help of ICT in moving things rolling for USC. But then again, the thing that was referred by Dr. Shankar also, that we shouldn't lose the human touch. We should remember that at the end of the day, the patients are human beings, and we should be responsive. It shouldn't be just a number game. So I think we should also keep that in our mind. And whatever we do, I think the people should be at the center. So it should be appreciated, owned by the people, whatever technology we introduce. So I think that's we should remember. Okay. So with this, I thank all the audience for your patient hearing. I think you have enjoyed. If you have more questions, I'm sure you will be having more opportunity while interacting during the breaks, during the lunch breaks. So with this, I just call this session, and thank you very much.
Thank you, sir, the chair, co-chair, and the presenters for this lively session. And thank you, audience, for your spontaneous participation in the discussion. Our next session is going to start right now. We thank all of you for your patient hearing.
Respected guests and participants, we are now going to start our next session. The theme of the session is Creating a Vision for Success, Way Forward in Ilahi Chaudhuri, Scientist and Acting Director, Universal Health Coverage Program. ICDDRB will be the co-chair of this session.
We have 5 presenters for this session, and they are Dr. Aminul Islam, Deputy Director, Health Economics Unit, Ministry of Health and Family Welfare, Mr. Mahbub Alam, National Program Officer, Population Planning and Research, UNFPA, Dr. Ashish Kumar Shaha sir, Divisional Director, Health Rajshahi, Dr. Ajam Ali, Team Leader, Urban Health System Strengthening Project, and Mr. Mamunur Rashid Bhuiya, E-Service Specialist, Access to Information. I would like to welcome the Honorable Chair, the Co-Chair, and the presenters to come up on the dais, and I would like to request the respected Chair and Co-Chair to conduct the session. Thank you.